So, Dugald Seeley leads the Ottawa Integrative Cancer Center program. He is a naturopathic physician, graduated from the Canadian College of Naturopathic Medicine. He's an affiliate investigator at the Ottawa Hospital Research Institute and a board member of the Society for Integrative Oncology. And I first met Dugald up in Toronto, was it 5 or 6 years ago? Let's see, at the Holistic Medicine Conference, you were talking about melatonin research and cancer. And so here's what I want to say about the naturopaths. And I'm so pleased to be associated. We have Dr. Kallmeyer on our staff. And what I really like about naturopathic medicine is that it is the same medical school curriculum, but woven into it is all of the pathways, all of the herbs, all of the detox things, all of the holistic part. All of that is woven in a highly scientific way. And so I think it was, who was the first president of Bastyr? Dr. Porzorno. Dr. Porzorno really hit it on the head when he said, if we want this medicine to be the medicine of the future, we're going to have to do the science. We're going to have to know the science, because that is kind of the bottom line of this. It's great to have anecdotes. It's great to have our own personal experiences, and we know in our gut how great it is, but if it's going to grow and serve humanity, we have to do the science. And fortunately, in our modern time, we have the scientific methodology to do it. I mean, this medicine's, the roots of this medicine come from a time when the science wasn't all that good, but really pharmacology, interestingly enough, has really given us a lot of technology and knowledge with which to study the herbs and to study the various natural therapies that we have at our command these days. And so it's great to have the naturopaths kind of integrated hold or understanding of how this fits in to both the natural side and the conventional side as well. And so with that, I would like for you to welcome Dr. Dugald Seeley. He's going to talk to us about his findings on a prospective cohort study on IV vitamin C and cancer. And do you need a pointer?
If you have one, that'd be great.
There we go.
Okay, great, thanks. All right. Sorry, just trying to bring up the, here we go.
Oh, yeah.
Okay. Yeah, good.
Yeah, just use the
Okay, great. Thanks. Well, good morning, everyone. And first of all, I'd really like to thank Dr. Hunninghake for the invitation to come be here and to speak to you today. I've wanted to come to this conference for a long time, and really delighted to be here. So just what I'm going to speak to you about this morning really is a little bit of a background on IVC. I'm sure very much a review, and won't spend much time on that. Then we talk a little bit about the systematic review that we completed that was published just last year in the Integrative Cancer Therapies. That's Dr. Block's journal. And talk a little bit about the results from that, specifically around high-dose IV vitamin C. And then I will stress the early findings from our prospective cohort study, which we have ongoing. I was really hoping to actually have more of an update for you on this, but in any case, it will give you a flavor for the research that we're doing, and a little bit of data on that. So for ascorbic vitamin C, most humans, like most primates and our close cousins, the guinea pigs, we have lost the ability to produce vitamin C. And so we're reliant on dietary consumption, or in some cases, intravenous consumption of vitamin C. If we look at the elimination half-life of ascorbic acid, for high dose, we're looking at something that's roughly on the order of 2 hours. So it's relatively quickly excreted. However, there's some differences depending on the deficiency level in the person in terms of what they retain in different tissues as well. There's a two-compartmental model for the pharmacokinetics, really into the serum, and then differential uptake into different tissues and cells, with certain tissues taking up vitamin C at a much higher concentration than others. We know from oral consumption that plasma concentrations don't really exceed much more beyond 100 micromolar, where you can get up to maximal concentrations through oral supplementation up to 250 micromolar. I don't think there's been adequate study on liposomal vitamin C as far as oral uptake, so that may change that number a little bit. However, this is sort of the current data that we have as far as oral consumption goes. If we're looking at IV injection, of course, this is where we can get much higher concentrations in the blood, and we're looking at 20, 30, or even up to almost 50 millimolar concentrations that are provided, that have been achieved. And this is really 200-fold what we're able to achieve from oral consumption. And the levels in vitro and in animal studies that have shown cytotoxicity from the use of ascorbic acid is really at doses that are greater than 10 millimolar typically. And that seems to be the threshold point for most studies at which point there is cytotoxicity. And this has been demonstrated over and over again in multiple different preclinical models. So a very strong biological rationale for the use of vitamin C, and particularly IV vitamin C. I think we understand oral vitamin C as being more of an antioxidant, whereas IVC as producing more of a pro-oxidative effect. However, that being said, there is antioxidant effects from IV high dose, certainly at the end state, at the later, as it diminishes from the blood, and also perhaps in certain compartments as well. But certainly from the cancer perspective, we're looking at the pro-oxidative effect with the high dose concentrations. I think the way to distinguish between high versus low dose IV vitamin C, and there's a bit of a debate around where the threshold is between high and low dose, is really dependent on whether you're trying to achieve a pro-oxidative effect or an antioxidative effect. And so with that goal in mind, the high considerations have been between 15 and 25 gram infusions given at a rate between 0.5 and 1 gram per minute. And really the effect and the concentration is dependent on the rate of infusion, the osmolarity of the infusion, and the dose, of course, that's provided in the bag as well. So there's a great study if you're ever looking to demonstrate the safety of intravenous vitamin C to anyone. Padayati and PLOS 1 2010 published a survey and a review from the industry of the use of intravenous vitamin C, looking at different CAM practitioners at CAM conferences between 2006 2008, found that 84% of CAM practitioners, of the respondents in any case, reported using IVC for conditions including cancer. So quite a high proportion, at least, of those respondents. And quite a large majority, a number of them were doing this for breast cancer, and then 20 to 30% for other types of cancer as well. So based on survey results and industry sales, there was the sort of estimation that 10,000 patients had been treated with IV ascorbic acid at 20 sessions per patient, dosing average of ½ gram per kilogram, with a remarkable safety profile. So no surprise there, but good evidence in a decent journal that can be used, and it's open access. PLOS 1 is open access. So I just want to go sort of back first to some of the very early interest before jumping into the systematic review. The first study that really generated some interest around the use of IV vitamin C was by Cameron Pauling in 1974, and they looked at 50 cases in a hospital in Scotland, and they did a case series, and they looked and they just showed some remarkable survival benefit in a number of these patients. Of course, one of the big weaknesses for the study that it was totally uncontrolled and it was case-based. But that said, it certainly showed a signal that was very interesting. In 1976, they did a follow-up observational study that was published in the Proceedings of the National Academy of Science. And actually, if you get your hands on this paper, it's really quite well written, particularly for a 1970s paper. So it's a nice paper to read. All three of their papers are, in fact. But here you can see the different cases. So this is just a subset of the cases that they looked at. Here the primary type is stomach. If you look through the whole chart, there's a number of different cancer types, and then they have their characteristics here, and then we're looking at their match controls. So they did match these retrospectively to patients in the same hospital. And in that retrospective analysis, however, there were 200 of those 1,000 patients in the control group were actually contemporaneous, or were sort of, in a sense, almost like a prospective comparison. So not bad as far as data. And that they mentioned that there was no significant change in the treatment of patients with advanced cancer in the Vail Hospital during the last 10 years. So they were cognizant of this comparison issue between their controls and the cases. And we looked at the study quality of these as well in our review, looking at the Newcastle Ottawa scale for analysis for quality. And these ones actually came up quite high. They scored 7 out of 8, which is decent for an observational study, very decent. So then, just another quote directly from the paper here. Well, first of all, I'll just show you on the chart here. This shows the data as far as the patients receiving ascorbate are these lighter columns here. And you can see that the survival time is much, much higher. So this is your sort of log rank Kaplan-Meier type curve. However, these are columns. It doesn't show it as a curve. It just shows the column. So much, much better curve for the ascorbate group than for the non-ascorbate group. And so they contended that the use of 1,000 controls managed by the same clinicians in the same hospital over the last 10 years provides a sound basis for this comparative study. And I would agree. So this is, again, looking at the different cancer types. This is a summary. So these are the different cancer types. And these were all untreatable, essentially. They were very advanced cases. And this looks at their survival time for each of these. In the B column is the group that were treated with the ascorbic acid, whereas in the C column were the controls, or the match controls that they used. And that, again, is a summary of looking at 10-to-1 ratio of matched controls to actual cases. So it's not looking at just one match control. They tried to average under a good number of controls. And this shows the ratio of survival. So 3-fold, 7-fold, and so on, with a total 4.16-fold increased rate of survival for those, or average duration of survival, I should say. And their conclusion, and this is direct quotes from the studies, is that we conclude that there's a strong evidence that treatment of patients in Scotland with terminal untreatable cancer with about 10 grams of ascorbate per day increased the survival time by a factor of almost 3 for most, and by at least 20 for a few. It's our opinion that a similar effect would be found for untreatable patients in other countries. Larger amounts than 10 grams per day might have a greater effect. So, pretty strong conclusions. In 1978, to address concerns that were raised by many different investigators, because this was such an outstanding effect, that they expressed doubt that there was really the ascorbate-treated patients and their controls truly comprise representative subpopulations, and that the comparable times of untreatability had been assigned to the two groups. So they decided to investigate these questions further. So in fact, they did a reanalysis. They threw out some of the original 100 cases that they had, and they threw out some of the match controls that they had, and tried to match more effectively, and they involved other people in that analysis as well. So here's the summary from that. You can see the different boxes show the different cancer types. This is for colon, stomach, bronchus, breast, kidney, rectum, bladder, and ovary. And here, colon especially, huge changes in terms of rates of survival. Same thing with kidney, breast. I mean, all of them are showing a dramatic effect. And this, of course, this is not something that they were selling on the side, making millions of dollars. So, that from a conflict of interest standpoint, I think this is an important thing to consider. Pauling definitely had developed a career around vitamin C, in a sense, you might say. So perhaps there's some conflict there. But I think that the openness of the data that was there is not, it really refutes that issue, and we know that he was certainly a very well-respected scientist with tons of integrity. So again, in their opinion, there is little doubt that treatment with ascorbate amounts of 10 grams per day or more is of real value in extending the life of patients with advanced cancer. Moreover, as being pointed out before, the quality of life was improved, and also we continue to believe that the addition of ascorbate to treatment regimens at an earlier stage might have a much greater effect, increasing average survival by several years. So again, very strong conclusions. So I just wanted to go back to that before we get into the systematic review, because I think it really generates the interest. And in some ways, this is the best data that we have because it's got the most number of patients. And it is a well-designed observational study, and it hasn't been effectively actually recreated in a randomized design. The two following studies in the Mayo Clinic, I'm sure people are familiar with, Mortal and I can't remember the other name, but they looked at oral doses of vitamin C. So it was not vitamin, and there was a number of other critiques of that. And actually, Dr. Block, Keith Block, wrote a really nice review of the comparator and some of the limitations associated with those follow-up studies, which are in the ICT journal. So our systematic review, we looked at really, does IVC improve tumor response, survival time, and quality of life in patients with cancer? And is it safe in combination with chemotherapy? We included all human level data. So we looked at RCTs, we looked for RCTs, phase 1 and 2 trials, observational studies, and case reports. And we looked at outcomes associated with the use of intravenous vitamin C, so not high dose oral, but just IV use for response rates, survival, side effects for chemo, and quality of life, and interaction issues as well. So we looked at a number of typical databases from a systematic review standpoint, and we limited our publications to English language. So this is one limitation, and it's current to May 2013. One other limitation to the study is that we did not do an analysis for well, I'm blanking on the word right now. Publication bias. So we didn't do analysis from that standpoint. So that potentially could be a limitation as well. So we excluded orally based vitamin C, and regardless of dosing, and we didn't include any preclinical studies in our review. This breaks down the flow chart according to a Prisma diagram for systematic review. So you can see we had 897 records that were reviewed, 770 immediately rejected looking at the abstracts or the titles. We looked at 127 fully. From that, we excluded 88, a number of reviews, of course, and then finally included 39 articles for extraction and analysis. We found 2 RCTs, one on high dose, which I'll talk about. I will not really speak about the one on low dose except as a generality, because it was 1 gram. And then there's 17 reports of 15 phase 1 and 2 trials, 8 trials looking at high dose, again, which we'll discuss briefly, 6 observational studies, and 14 case reports in total. So the high dose one, IVC for our randomized control trial, probably many of you are familiar with this trial. It was published by Yan Ma and colleagues, including Jeannie Driscoll from Kansas University just this year. And this randomized 27 ovarian cancer patients who are late stage. And in one arm, they were given IVC at twice a week for 6 months, 75 to 100 grams. During chemo, and then 6 months after chemo. So it was a year treatment, in fact, twice a week at a very high dose, or high dose, let's say. So that was the treatment arm, and then the control was just given chemo and then followed for the 6 months after that as well. So it was a dose escalation, I think very similar to the protocol that's used here as well. So the results showed very clearly that there was a dramatic, highly statistically significant difference in terms of side effects associated with chemotherapy. So they looked at neurotoxicity, bone marrow toxicity, infection, hepatobiliary, pancreatic, renal, genitourinary, pulmonary, gastrointestinal, dermatological, so all across the board. Very dramatic response in terms of some of the side effects. And then when they looked at the survival analysis, again, this is only 27 patients. It wasn't powered for this, but they did show a trend towards longer time to relapse and mortality. And this was a nearly 9-month difference. So from a clinical standpoint, very significant for the patient. This would be a huge blockbuster drug, of course, but it wasn't able to achieve that statistical significance based on the numbers. So this desperately needs to be replicated in a larger group of patients, and it's perfectly suited for it because they have this safety data and all kinds of other data. So this would be one that should be jumped on by ASCO and say, let's repeat this trial in 1,000 patients. But of course, we know that won't happen. Looking then at phase 1 and 2 studies, these are the high-dose studies. These are the publications, and we'll review them according to whether or not they looked at safety and efficacy, or pharmacokinetic outcomes, which they did analysis for as well. So here is the breakdown. So really, there's a variety of doses that were used. A large majority of them used around 50 grams or more, achieving concentrations of 20 millimolar or more, and given in schedules basically comparable to what's usually used in the field. And so we see that actually from the Stevenson trial, this is the one that achieved the maximal concentration of the blood at 49 millimolar, and that was the recommendation, was to go ahead with that dose at a 70 grams per square meter, which is, I believe, 180 grams for someone, 140 grams for someone who would be 180 pounds at 6 feet. So that's sort of the comparison there. That was their recommendation to go forward with studies at that maximal dose. So if we look at the efficacy findings from these phase 1 and 2 trials, here's the MA study, again showing that trend and definite improvement in terms of side effects. And then here, there's some improvement in side effects. Didn't look in the Stevenson study at response and survival. There is some combinations with chemotherapy here. Again, some response around survival and improvement in quality of life. Tumor response here in the Monty study in 2012, and then more effects as far as quality of life and performance scores. So in the anti-tumor and survival outcomes that were looked at, there's the MA study at the top. Then in 2012, Welsh and colleagues looked at stage 4 pancreatic cancer in 15 patients. Mean survival was 13 months roughly, and the performance status did improve. Now this was not controlled, so we don't know, but according to sort of standard controls, this would be considered a good response for these patients. And then in the Monty 2012, again looking at stage 4 pancreatic cancer patients, in a very small subset of patients, only 14. These are very small trials. They looked at a tumor mass decrease, and mean progression-free survival was 89 days, and overall survival 182 days. So again, better than normals, if you will, but it doesn't have a control embedded within the trial. But these are signals for improvement for sure. If we look at the quality of life and symptoms score outcomes, there's the MA study, and Stevenson study showed improvement in quality of life for patients who made it to 3 or 4 weeks of treatment. In the Welsh study, there was a performance status improvement. In the Hoffer study in 2008, physical function using the FACT-G score did deteriorate in the lowest dose group, but not in the higher dose group. So some dose response perhaps showing in this example here. And then in Yom 2007, there was an improvement in the global health score after vitamin C, and also improvement in the functional scales that were used. So turning now to the observational studies, here are the different ones that you can look at, see. So it shows the different populations, the characteristics of the patients that were in these different studies. Only one reported on the type of chemotherapy. These, there's no reports. There was no use in the Cameroon Pauling studies. And then again, here we're looking at tumor response and survival, and we'll speak a bit more to that. Here, this shows the summary effects for those Cameroon and Pauling studies as well, and then quality of life and cancer symptom scores on the far right. So in the study by Mirakova in 2012, which has been talked about already before, really interesting, I think, in terms of its effect on some of the surrogates associated with inflammation, particularly CRP. For prostate cancer patients, there is a correlation with the reduction in PSA along with a correlation and a reduction in CRP there. So perhaps this is a measure that we can look at as far as if there's any effect in patients. Maybe it's the patients that have a reduction in CRP that are going to be more likely to have a beneficial effect. I don't know if that's true, but it's a hypothesis anyways. Then they looked at 50-gram treatments 3 times a week with a median of 9 treatments in a number of different cancer patients. They also showed some non-specific, non-significant, but trends to reductions in different tumor markers, as well as anti-inflammatory cytokines. In 2012, Takahashi's study, which was a prospective cohort for 60 patients, they were newly diagnosed with advanced cancer. They were escalated to 50 grams, then adjusted to achieve 350 to 400 milligram per deciliter dose. There seems to be a lot of consistency on dosing, which is nice in these studies and in the application. And this was given twice a week for 4 weeks. They looked at quality of life using a European Quality of Life score, the EORTC, and it was improved after 2 and 4 weeks in these patients. And then there is they looked at symptoms that also improved, including fatigue, pain, insomnia, constipation, and physical function, and the global impression score, which also improved as well, up to 60% at 4 weeks. So in the study by Volbracht in 2011, this was a retrospective cohort, slightly larger with 125, and they compared 53 that were given IVC versus 72 that were not. Early stage breast cancer patients given relatively low dose of vitamin C. This is actually a formulation that they package in Europe, and this was done in Germany, of 7.5 grams, and they'll give this as it's almost like a pharmacological prescription that you get 7.5 grams in a vial, and that will be used in these for patients. So they've sort of landed on this as their standard in some ways, or I guess some of the groups in Germany, I would say. So it was minimum 4 weeks alongside chemotherapy and radiation, and they showed significant reductions in chemo and side effects, symptoms of nausea, fatigue, depression, sleep disorders, and others. And there was a twofold higher improvement in terms of the symptom scores in versus the control group. Here again, this just goes through the regime. The chemotherapy that was used in these patients was typical for breast cancer patients, epirubicin, cyclophosphamide, at the highest proportion there. You can see the other chemotherapeutic agents that were used. So again, I won't go through, well, I'll go through this briefly as far as the Cameroon and Pauling data. So the earlier studies showed a 4-fold increase, a 5.6-fold increase, and then a 1.9-fold or nearly 2-fold increase in survival in the later study. And that was actually a larger group, but interesting.
Do you have higher doses of vitamin C besides 10 grams?
It was in the last study, it was a higher dose. Yeah. So in case-based studies, there's 14 publications reporting on a total of 221 different individual cases. And here, cancer remission, the key thing about these case reports that have been published, probably the most interesting findings are that, that these were unique cases according to survival for a long time, past life expectancy, and that there may have been initial disease stabilization in many of these cases, but then there was recurrence or death after IVC had been stopped. And again, that's sort of what we're hearing in the conference and what I've heard as well. So these are anecdotal in the sense, they're case reports, of course, they're totally uncontrolled, but they certainly are a signal and a pretty potent signal. And obviously for those patients that have this, and maybe if there is a subset of patients that are really going to respond to IVC, and I think that's a really interesting area for research, is how to define patients that respond well, and when do we, so who do we target? But as far as cancer types, you can't really isolate 1 or 2 cancer types that seem to respond well to this. Right across the board, there seems to be some effect. Of course, these are just a few here and there, but there doesn't seem to be any specificity to cancer type, which is pretty interesting. So who spoke about the fact that if there's not a specific drug, it was Dr. Berkson around alpha-lipoic acid. Well, this is probably a good reason why this is not getting taken up, of course. So if we look at the interactions data from the human studies, this just shows some of the different chemotherapeutic agents that have been tested in humans. These ones here and these ones here are the high dose ones, as well as the pink ones are the ones used in breast cancer. And these are the high dose ones, and these ones were used with the low dose IVC. So I haven't gone through the low dose IVC studies, but what they did show was that there was a lack of interaction. And the whole idea that the antioxidant debate or controversy that's going to quench the effect of chemotherapy, I think at least for these ones, has been not put to rest entirely, but it's addressed because the low dose ones are generating that antioxidant effect. And then here we see, a range of them as well. This wasn't published in the study in the systematic review, and actually a lot of credit should go to Dr. Paul Anderson, who has done a lot of research in terms of interactions between chemotherapy and IVC. He's a clinician in Seattle, and they use a lot of this. So here are just a list of the different chemotherapeutic agents that have been tested either in basic science, in vitro, in vivo, or actually in humans. And wherever you see a plus, it shows indeed that there's a synergistic effect. So it seems to augment the effectiveness of vitamin C therapy. Where there's a minus, where we're looking at less than 5% of the studies here, there is it shows that there's a negative effect. So I've highlighted the bortezomib. Of course, there is one study in humans that shows no interaction. And then there's this one here that's got a negative interaction there. But by and large, we're showing from all the science that there's no worries for interactions with chemotherapy. And if anything, it should be augmenting effect. And I think that's probably where the best effect may be achieved is through combination with chemotherapy. I won't go into much on the mechanism that's been discussed. There's many people here that know this much, much better than I do. But just looking at some of the issues, of course, the catalase, the deficiency of catalase that exists in cancer cells, causing that hydrogen peroxide to have a specific cell-killing effect in cancer cells, seems to be very clearly made from preclinical studies, and it's been demonstrated whenever catalase is added that this totally diminishes that effect, that cell-killing effect. So we know that the mechanism pretty strongly in terms of that pro-oxidative effect. And there's also a preferential uptake. The glucose transport mechanisms in the cells are upregulated in cancer cells, and it's sort of like a molecular mimic between glucose and vitamin C. And they seem to increase genotoxic damage in the cells, as well as metabolic by reduction of ATP, so their ability to generate energy seems to be depleted as well. There's also the theory that the collagen buildup will reduce the ability for cancer cells to migrate and to metastasize. It has anti-angiogenic effects, pro-apoptotic effects, and then it will affect cell signaling through mTOR and VEGF and NF-kappa B. So a number of mechanisms that have been studied. And I don't think, not as well as the hydrogen peroxide, but these are there. So some of the side effects that we identified in the systematic review, nausea and headache due to osmotic load, transiently there, really corrected by eating and drinking. Dose-limiting toxicities, there are 3 incidents of grade 4 hypernatremia, and 3 of hypokalemia. So some suggestion has been made in the higher doses to provide potassium chloride, for example, as an adjunct. We don't do that ourselves, but I know that some people do. Then there's other adverse effects that are probably more associated with the actual conventional therapy, but it's impossible to tease that out in certain cases. So contraindications to the use of IV vitamin C, well, G6PD deficiency is the key one. That's there due to the potential risk for hemolysis. And for advanced cancer, that there may be a risk of acute tumor hemorrhage or necrosis. So a gradual dose escalation makes more sense in that sense. So most people have adopted this gradual dose escalation to prevent against that, but there's very few reports, in fact, that this has happened, I believe 1 or 2. The other one that isn't really talked about much is the potential for patients with multiple recent transfusions. And could this shift possibly create an artificial G6PD deficiency in the blood? So someone who's got multiple transfusions, you may want to consider whether or not maybe there's a test for that, or to do lower doses for that patient at that time. And oxalate stone formers and iron overloads, I would say, are relative contraindications. I think these are a bit overblown. There is a case for oxalate. I haven't actually seen of any crises with someone with hemochromatosis in the literature, nor heard about it, but it seems to be a theoretical contraindication. So just to show that this did in fact get published, this is an ICT in 2014, and so the review of the systematic review is that the anti-cancer ascorbic acid concentrations are achievable easily through the phase 1 and 2 studies that we've seen, that there are definitely improvements apparent in chemotherapy and side effect and cancer symptoms from human level data, and quality of life and performance score is improved, and that there's a survival benefit potential alongside certainly paclitaxel and carboplatin from an RCT with the ovarian cancer in the MOS study, and that survival benefit in advanced cancers seems to be likely or very, very plausible, and that interactions that are safe with several chemotherapeutics and in fact may augment chemotherapy effectiveness in some cases. And so I would say from the weight, the totality of the evidence as it stands right now is highly promising and deserves large-scale trials in various cancer types. Okay, so that's the end of the systematic review. I'm going to speak a little bit about the observational study, but did you hear about why the scarecrow won the Nobel Prize? He was out there standing in the field. He was outstanding in his field. I just totally screwed that up. It was my attempt at a joke. Okay. We should have like a yoga break or something, I feel like, but no. But so in our observational study, we really we're trying to break down two parts. One is a 1-year prospective cohort study, and then the other is a 5-year cohort study. So the first, the one on 1 year, this is the same group of people that we're looking at, but we want to look at quality of life for people living with breast, lung, pancreatic, colorectal, and ovarian cancer. And then over 5 years, we want to see what their rates of survival are and how that differs to norms. So our hypotheses for this study is that people choosing IV vitamin C will demonstrate a relative increase in their quality of life, a relative improvement in common cancer-related symptoms, a relative improvement in patient-identified concerns. They would experience mild and infrequent side effects, and that they would have an increased rate of 5-year survival. So our study design for the first-year prospective, we're looking at treatment, the treatment group getting IV vitamin C at least twice a week. Now, this is an observational study, so to fall within the category of being in this treatment group, they have to self-select to have IV vitamin C twice a week for at least 12 weeks. This is actually posing a bit of a challenge for us to get this level of data and to get patients that are indeed interested enough in the study. So our recruitment is not where we want it to be, and we're working on that. But in any case, to be included in the treatment group, they need to have this level of IV vitamin C. So we required this threshold level. And then they would also receive individualized integrative care at either the OICC, which is our center, my center, and then or the center in Toronto, which is the Robert Shad Naturopathic Clinic, which also has an advanced cancer clinic there. And then our 5-year prospective cohort study, we're going to compare the treatment group, which receives integrative care, including IV vitamin C, to controls in a registry at the Ontario Cancer Registry. So that's the goal. So our setting is we have at the OICC and particularly, and I'll speak to that, and then RSNC as well, but we have a multidisciplinary team that meet different needs. So they're credentialed in cancer care with clearly defined roles and scopes of practice. There's communication amongst the practitioners, both informally through case presentations as well and then also through the use of electronic medical records. And there's a care coordinator that works with the very small research department that we have in terms of conducting and following the patients and consenting them. So the critical points of patient contact, which is going to be familiar to anyone who treats cancer patients, we've broken it down to first, second, and third stage. First stage, where people are just diagnosed and they're coming and they've got a sense of bewilderment and they really lack of control, a lot of anxiety. So there's a lot that we try to do, especially from a mind-body standpoint, to help them regain some control. Including decision-making about what types of complementary therapies that they want to embark on, because it's a big decision. Many people haven't had exposure to it before, and so that's part of that discussion. In the second stage, we see perhaps the majority, I would say, the majority of our patients are in this stage. They're working in conjunction with conventional chemotherapy or radiation or post-surgery, or in planning for surgery, and they're looking at, and we're talking about potential for interactions, what we can do to support them through that care. And then the third stage, which is more the healing journey, if you will, or aftercare. They've been released from the hospital. They don't know what to do. They don't know where they want to, they want to have more control. So we offer them more sort of prevention-based therapies, or if it's much more advanced, then we're going to be more aggressively trying to treat them. So really a range, and I would say just over 50% of our patients have advanced stage 4 cancer, stage 3 or stage 4 cancer. So that seems to be the majority. We're trying to reach out for more primary prevention, but we're not really getting much uptake. People are not as interested at that point. So the patient's treatment related needs and challenges, really, they're looking at decreasing side effects from conventional treatment. They want, in some cases, and I think there is evidence to support the effects of conventional treatment, I would put IV vitamin C in that category. There's a preparation before and after surgery. They're looking in symptom management just in general. Of course, immune support is always a major issue, and we do look at that. They're looking, definitely people are coming for a cure. Many people put that on one of the reasons they want the cure. You know, we have a lot of discussion with them about this is not curative therapy, but supportive therapy, and we're trying to get them as much longevity and anyways, you know that discussion. But but this is obviously at the core of many people's desire, as well as quality of life. And then there's a lot of information decision-making support, crisis management for stress and anxiety, particularly at that first stage, and then trying to help people regain some personal sense of their own power and a sense of self as well. So integrative oncology, which is, I think, very much part of what everyone here is involved in, we try to achieve that through lifestyle and behavioral modifications, looking at nutrition, dietary supplementation, physical activity, stress, relaxation, sleep. So all those like foundational elements of people's health that we look to try to help them with and to address. And of course, some people's priorities lie in different areas. But we also look at the internal dynamics and their physiology. So we look at oxidation, we look at inflammation, the immune system, growth signals or hormonal effects that may be on cancer as well. And we look at energy metabolism. And I think this idea and that cancer is a metabolic disease is absolutely the case, and it really provides some amazing tools now to go after for treatment. And then we look at a rational inclusion with their conventional therapy, as well as what's financially feasible for patients, because of course they could do everything and spend, gazillions of dollars on all this. So there has to be a discussion about that as well. So the therapists available at the, I won't list through all these, but these are the different therapists that we have available at the OICC that are part of this integrative team that provide care for the patients and are available. And so we do have naturopathic medicine is sort of one of the core, is the core in the sense. Almost 90% of the patients would see a naturopathic doctor, and then would see a number of the different other practitioners as well. Most would, we have 3 nurses that work with our integrative medical doctor, and that is a process that we use as far as engaging people in the intravenous vitamin C process. So there's obviously every province or state have different regulatory issues that you need to be aware of. And for our nurses to work with the integrative medical doctor under a directive, this is what we have created. So the integrative therapies at the OICC include I've put natural health products at the top here. That doesn't mean they're the first priority, but we certainly do use quite a bit of them. So just to give you a sense of some of the key things that we would use in our integrative care, these are just some of the examples of natural health products and some of the major examples, I would say. And then there's the injection therapies. We have vitamin C, dichloroacetate, mistletoe in subcutaneous form at this point, and alpha-lipoic acid as well. And then where there's some off-label use of oral medications, including metformin, LDN, and aspirin, and mind-body medicine, the different components there that are there. And this should probably be at the top in many ways, but there it is. And then we've got nutritionally targeted approaches, which we're using more and more of. So the ketogenic approach that one of the physicians here spoke about yesterday is something that I'm very excited about. I think it has a lot of promise. So we're using this more actively, especially with more aggressive cancers. However, it's very difficult for patients to really embark on a ketogenic diet. So having that issue around anxiety, and I think turning the alarm bell on in the brain is a good one. We don't want to do that, and we don't want to have them leave, say, with a sense of failure, having not been able to do this dietary approach that could have cured them, or their family member may have thought that could have cured them. So it's a really careful discussion, and we really try to work with the patient as far as that. And I think it's important to not jump on the ketogenic bandwagon before you've thought about how to support your patients through that. So I just make a point for that. We use a lot of functional foods. We do look at low-carb diets, reducing the energy and the fuel that may be there for cancer cells, especially in the IGF-1 and all that. And then also, the other one that I'm really interested in is the caloric restriction before chemotherapy. We've had a few cases where we use this, and patients have tolerated the chemotherapy remarkably well. And it's not as intense as a ketogenic diet because it's a temporary, but I think that you can achieve certain things with that. Okay, so that just gives you a sense of the integrative care that all the patients are subjected to, if you will, in this cohort study. So, but what we're trying to do is we're looking at a subset that are in the treatment group that are receiving intravenous vitamin C therapy as well as the other integrative modalities. So that's our goal, again, is to have 120 in our treatment group and 120 in our control group. We have 2 in our treatment group right now. So we're not quite a year into recruitment, but the challenges for any of these studies is recruitment. And it looks great on paper and all the rest, but when you try to get patients to fill out the forms, you try to get the clinicians to be involved in supporting the study, even though there can be a lot of discussion about that, it's a challenging process, especially when you're trying to collect a lot of data. So we're looking at how we can adapt this a little bit to make it more, improve our recruitment. We've got over nearly 40 in the control group. So we've got a lot of patients, and we've got a lot of patients in the IVC, but we're not effectively recruiting the ones that are going through enough of the therapy. So we're looking at that. So I just wanted to mention that. And then our registry matches that we're going to be doing is we're going to be doing a 2-to-1 comparison of matches from the registry in terms of key demographic issues and stage of cancer to look at survival analysis over the 5-year time point. So here's a bit of a schema for the process of recruitment that we use. So patient registration, we look at their demographic and disease information, their health history, and then they do an initial baseline completion of the quality of life tools and outcomes that we're looking at. So ESAS, the EORTC, and MICAR are 3 of them. We'll talk a little bit more about those. But those are the 3 outcome tools that we're using for quality of life predominantly. And then there's a care coordination process, so we sort of integrate the research element into this. But they're dealing with so much, so recruiting at an early stage, right at baseline, is actually very difficult because they're just like, it's too much. They filled out so many forms, and it's like, that's just over the limit, so they don't want to do it. So that's our biggest challenge. And then for follow-up outcomes, we're looking at 12 weeks, 6 months, 1 year for our quality of life outcomes, our questionnaires. So 4 in total with baseline. And then at years 2 through 5, we're looking at survival and recurrence. And the 2 study sites are the OICC and the RSNC. and most are really coming through from the OICC. So here are the different validated questionnaires. ESAS, have anyone heard of these outcomes tools? Are these new or? Okay, well, these are, the ESAS is a nice short questionnaire which gives you a way of tracking physical function aspects. And I'll show you the outcomes on those so you'll have a sense more of that. But it's not a very involved process. So it's one of the, it's one of the better tools, and it's also well recognized. So if you're looking at publishing or tracking outcomes, it's a good one to have. Then there's EORTC, which is, again, is a quality of life questionnaire. It's a little bit longer, but not too bad. It takes about maybe 5-7 minutes, I suppose, at the outside to complete it. And it's broken down into different functional domains. So it's a way of categorizing these different outcomes. And then MyCaw, which is a measure yourself tool for symptoms and well-being for cancer symptoms and well-being. This is this tracks individualized chief complaints. So it's a really interesting one because if you have some patient who's got migraines all the time, for example, then they might say that this is their chief complaint, and they would put it down. And so it allows you to track that outcome over time in a sort of formalized way. And really interesting data can come out of that. So here are the data collection tools that we have. Our primary is the EORTC, and we're looking at these different measurement time points. Adverse events we're looking at throughout as well, and cancer-related symptoms. So here's the patient demographics for our total of 36 patients that we have. Vast majority are female, and it's sort of a good distribution between early and advanced. The yes and no really means if there's IVC use or not at that threshold point of 12 weeks of treatment of twice per week. And in here, you can see that we've only got 2, and our 2 are here for female, and one is between 30 and 39, one is between 50, 59, and they both have advanced stage 4 disease, okay? So that's, and then this shows the level of education that they have, as well as the household income. So you can see a distribution, certainly a lot are quite affluent, over 140,000 household income per year. That's the majority, but there is a range, and the range of ages that we have as well. So here is it in terms of the staging that we have, again, a large proportion that have breast cancer and ovarian cancer are really responsible for that heavy weighted proportion as far as the number of female patients that we have in the study. And that this is again broken down into early versus advanced. So the IVC intervention for those patients that are categorized in that category, that we're looking at dose escalation. This is for anyone who's receiving IVC. It's a standard protocol where we go from 15 up to at least 40, and it's given with magnesium chloride. There was some discussion yesterday about the use of glucometers. We do, in fact, use glucometer as a surrogate for blood concentrations. We've correlated it to weight. There seems to be some correlation there, so it's not perfect. And it would be nice to be able to do the analysis for actual blood levels. But we find this a good tool. And we do change it based on the glucometer. So the glucometer that we use actually gives us a reading, and we try to be between 350 and 400. And that's the difference in a glucometer reading at the initial, before they are receiving the IVC, and then at the end of the IVC as well. 8 of our 36 patients to date have ever used IVC. We had 2 that only got to the dose escalation, 1 that achieved 6 treatments at 60 grams, 2 that reached 9 treatments at 50 grams, and then we've got dose escalation plus at least 12 treatments, and they're at 40 and 50 grams each. So that's where we have our 2 that have reached that threshold point. How am I doing for time? Okay, thanks. So our IVC users, they're both breast cancer patients, both stage 4, estrogen receptor positive, both married and Caucasian. They've received each actually 30 treatments at the point of analysis, and they've both received significant amounts of conventional therapy, no surprise given the fact that their staging is where it is. Here are the scores as far as the Edmonton assessment score, so that you can look at the different outcomes. There's pain, tiredness, and drowsiness. A little bit of an odd, I'm not sure why this is there, but they have that drowsiness versus tiredness. There's nausea, appetite, shortness of breath, depression, anxiety, and then this is well-being. So this worsening of symptoms is on the up part, and improvement is on the down. So the IVC group, and we for this analysis, I only compared the advanced cancer patients to get a little bit of an apples-to-apples comparison. So the non-IVC use are combined of advanced breast and advanced ovarian cancer patients, but they're both advanced. And so we can see that in the IVC use, we're seeing improvements in the majority of this, actually worsening in the tiredness, but majority here, and a dramatic improvement in well-being. Again, big caveat, there's only 2 patients in our advanced group. So that's the ESAS, and that's from 6 months to baseline as far as the change goes. And so here we've got the EORTC, and again, in this case, deterioration is again on the upscale here, and you can see IVC use in the blue, and financial difficulties is the one we're seeing in worsening for this outcome here, whereas most of the other ones we're seeing improvements actually across the board for all patients, but a little bit higher in the IVC group. And we didn't do any statistical analysis because it's just not worth it for this number of patients. It's just a descriptive analysis at this point. So here you can see these are the functional score changes, quality of life, and in this case, up is actually an improvement. There's a slight improvement, and then we see a slight improvement in cognitive function, and then relatively not as poor changes in emotional and social function and the other functions. So these are groupings of the different quality of life questions. Okay, so that's the data on our cohort study, where it stands right now. So hopefully in a couple of years we'll have this at a much richer point in terms of analysis, and we'll see if these continue to follow this type of trend. But at least from this data, you know, it doesn't refute any of the ideas that are coming through, and it's our small contribution to this point. So I did want to highlight some of the ongoing research that is actually active right now. Looking at clinicaltrials.gov, you can see a number of different trials that are looking at intravenous vitamin C use. Unfortunately, really not much coming through that are randomized. These are all small studies, 14 to 60 or so, largely in advanced cancer patients, but usually using the same sort of high dose that is being used in the field, so that's good. So here, and there's one by Hoffer et al. At Jewish General in Montreal. This is actually completed. They've looked at 14 studies, 1.5 grams per kilogram, infused over 90 to 120 minutes. This is in patients with advanced cancer, and they're not responsive to chemotherapy. I've heard, this is completed, I've heard a rumor that there was not beneficial effects that were seen in this, but that was just a rumor. So what's that? Is Dr. Hoffer here? No kidding. Okay. Dr. Hoffer. I don't know. I don't want to put you on the spot, but if you want to say anything about it. What's that? Sorry? Okay. All right. Well, we're excited to see that one. And then there's one by McInnes et al. At the Copenhagen University in Holland, looking at metastatic prostate cancer, weekly infusions. They're looking at PSA progression and changes in bone mets. So this is estimated to be done, at least from clinicaltrials.gov, in December 2014. We'll probably see these. These always get published like 3 or 4 years later, so don't be surprised with that. That one's there. And then there's one actually by a naturopathic doctor, Heather Wright, and Aiko Clement, who's an oncologist at CTCA. They're looking at metastatic pancreatic adenocarcinoma. Very small group, but they're looking, I think, to implement larger trials based on some preliminary data. So that's exciting. They're getting into the game of IVC research. And that's complete. There's no publication. Dr. Driscoll and colleagues are looking at advanced metastatic pancreatic cancer with gemcitabine. This is a 2-phase study. The first group of 7, they're looking at safety, and then if that pans out, they're going to add another 7. They will certainly be looking at survival, but it's not powered at all for that. Then there's one at the Citus in Arkansas, looking at metastatic pancreatic cancer with gemcitabine or advanced. Again, same sort of similar protocol that we're used to. 30 patients non-randomized. For some reason, it's suspended enrollment. And there's another one by Driscoll and colleagues looking at a phase 2 study in advanced cancers with no options for chemotherapy or radiation. This is slightly larger. It's not randomized, another phase 1 and 2, looking at maximal tolerated dose in this case. Lease et al. At CTCA, 18 patients looking at advanced solid cancers. Again, looking at quality, safety, and tolerability. We're always stuck with the safety and tolerability because if you ever want to get oncologists on board, well, you have to go through the process. So that really slows us down. And I think we've got enough safety and data to do a large-scale trial, but it's not happening yet. So we need to launch that. And then here, we've got another last one by Monty, who's published before, looking at FOLFOX with bevacizumab if the patients have progressed on this therapy for stage 4 colorectal. And it's 48 patients in that case, open label again. So those are some of the studies. That's probably only 50% of the studies that are ongoing. That's not all of them, but it's a number of them. And I just want to acknowledge Dr. Heidi Fritz, who's a naturopath and a colleague that's worked with us, and Laura Weeks as well, for a lot of the analysis that they've done and contribution to to many of the slides. I want to also acknowledge the contributing co-authors and collaborators, and we had anonymous donors support the systematic review, and the Ottawa Regional Cancer Foundation supported the cohort study. So thank you very much, and I know that these slides are relatively different from what you have in the syllabus, so I'd be happy to make those available for distribution. Okay, thanks very much.
Very good. Okay, very good. And Dugald will be back at 11:15 with Dr. Schallenberger, and we will have him open to questions. And we will have these kinds of, like if you want an updated PowerPoint, we'll have that available if you have your email address with us.